Mike.
I'll start with the laparoscopic management of pediatric inguinal hernias. Um, Let me tell you that although this pediatric inguinal hernias appears very simple and relatively easy topic, but in fact it's a very vast topic, and today we are not going into the details of all these intricacies and complications and whatnot. We'll just discuss the basics of the hernias, pediatric hernias, and the role of laparoscopy. So let us come to the basics. So this is a very interesting slide. That is a basic difference between the adult and the pediatric inguinal hernias. See that the first, that is a patent processus vaginalis. We all know what is a processus vaginalis. It is in the boys that when the testes descend, they carry along with a pouch of peritoneum, and that is called as processus vaginalis. In 20% of the patients, this processus vaginalis fails to close, and therefore we call it as a patent processus vaginalis. If that is there, then that will lead to hernia. But what about in girls? So we'll discuss this later on, because we often see girls with inguinal hernias. So if a girl child presents to you with inguinal hernia, then what is the cause? We'll discuss it later on. These connective tissue disorders, then prune belly syndrome, spinal dysraphisms, I have included this because in pediatric inguinal hernias, the only thing that we require to do is herniatomy, and we don't require to do hernioplasty or herniorrhaphy. See, whether it is a hernia or a hydrocele, I just told you that the etiology is patent processus vaginalis. So in pediatric hernias or hydrocele, the treatment is simple, that is do a herniatomy. That's it. Then what about the difference in the anatomy? In the neonates, in the newborn period, the superficial inguinal ring and the deep inguinal ring are almost overlapping. There is no development of the inguinal canal. But as far as the laparoscopy is concerned, this makes no difference. If you are doing an open surgery, then you need to know this. Most of the pediatric inguinal hernias are indirect because it is because of this. Very rarely you get direct hernias, and it is in these conditions. There is no role of mesh in pediatric hernias. This is an important slide. If the time permits, we'll discuss it later on at the end of the presentation. Now, what Prashant has already told us, the various instruments, the trocars and everything remains the same, but we use very tiny instruments. The optical trocar is just a 5mm trocar, and the hand instruments in neonates are 3mm, whereas in slightly older children, I use 5mm only hand instruments. The abdominal pressure, obviously in newborns, I don't go above 8mm of Hg, and later on beyond 5 years, then we can go up to 12mm, but preferably 10mm, that's it. Anesthesia, nowadays the anesthetists are also well trained, they are well conversant, and they are using regional anesthesia also, like spinal anesthesia in pediatrics. Some anesthetists don't prefer spinal because of their own reasons, but even the spinal anesthesia is comfortable. But in newborns, it is always general anesthesia. As far as the laparoscopic approach is concerned, there is total extraperitoneal. I removed the word total, you know why, I'll tell you just now. It is extraperitoneal, but the optical trocar is intraperitoneal, but the ligation of the sac is extraperitoneal, and therefore I removed the word total. And then other is the this is number 2, transperitoneal herniatomy. Now in extraperitoneal approach, You can call it as a single port also, because the only port that you introduce is a optical trocar via umbilicus. You don't require any hand instruments. What you require is a 18 gauge epidural needle or a 20 gauge epidural needle, then a PDA suture which is 30 for neonates and 20 for older children. The advantage is that it is very simple and very fast. It will just take 5 minutes, that's it. And the disadvantage is that there is a ligation in continuity. I'll explain this. So this is a 1-month baby, and there is a right scrotal testis with hernia, and there is a left hydrocele. Now as I play this video, you just observe it. I'll demonstrate also, and it is via umbilical 5mm port, that is optical port, and I have used here 20 mm epidural needle to pass a purse-ring suture. See here, this is the right opening at the deep ring. I don't know why it's not playing.
Audio visual, please help.
See, this is the right side opening, and I am introducing what we call an epidural needle, and these are the vessels, and this side is a vas. Can you appreciate that? The vas is a very
So this is single port.
This is a single port. The umbilical port is the optical port, and as you can see, I had passed in a loop through the skin. Now I am coming from the medial aspect, and through that I will pass a free end of the suture. Now what I will do, I will try to come through the same opening here, inside. So the free end is passed, it is engaged in it, and it is pulled out and closed. That's it. Very simple. Opposite side, now see that this was a hydrocele, and here the opening is very tiny. If you would appreciate it, on the right side the opening was very wide, and on the left side it was a very tiny opening. So epidural needle comes in with a loop.
Any chances of trauma to the vas?
No, that is what you have to take care while passing the from the medial side. So the loop is now inside. Then I will withdraw the needle and put it from the medial. And now this is coming from this side. And as you pass it, then again try to come to the same opening, and then pass the free end, engage in the loop. So free end is inside, the needle will go outside now, and the loop has engaged that free end, and I'll pull it out and then tie a purse-ring suture. That's it. Yeah, and it is tied. So pause करायचं बस झालं. Above that was the here. I'll go back again. See, this was the site for the umbilical port, and over here from the lateral and the medial aspect, what I did was I was passing a loop, and from one end I was passing a free thread. And what I did, this suture has a needle over it. So what you do is there are two distinct openings there. So you pass a needle from one opening to the other opening, and then here you tie a knot. That's it. So this is how it looks. That's a umbilical port, and these are the small tiny openings at the site of deep ring and on the right side. The next is a 3-year-old girl, and the procedure is simple. Do you want to play me again? Right. In a girl child, you are not worried here because there is no vas and there are no vessels. Even if you engage the round ligament, it's fine. This is the uterus. You look for the ovaries, that they are normal. I'll explain it why in girls, why I am looking for the uterus, why I am looking for the ovaries. I'll explain it later on. See, this is how now the loop is passed. It is coming from the lateral aspect. Then I'll withdraw the needle. Then I'll come from the medial aspect. Then pass a free end of the suture. This needle I'll try to come out through the same opening which I had created here. See that? And then pass a free edge and try to engage it in the loop. It's very easy. So the free end has come in, the needle will go out, the loop will engage that one, and we'll pull it out and then tie a knot outside. When the knot is tied, you see that it's closed. This is the uterus, this is the right ovary, here is the left ovary, this is the rectum. Now coming to the transperitoneal approach. In transperitoneal approach, you have this optical trocar and two hand instruments side by side. These are the 3 mm ports, and normally in neonates, now you see in neonates, in pediatrics, that is in older children, there is not much of problem, but in neonates, when you're doing it, you have to be careful because the umbilical vein is there, and if you enter the umbilical vein, it will cause a torrential bleeding, and down here are the umbilical arteries, so they are yet to obliterate. So what I do is in neonates, I just prefer to go by open method, that's it, so that you don't damage the umbilical vein. Switch on to again. So this is for bilateral inguinal hernia. This is a preferred method because what here, the difference between the previous one and this one is that here you are making a peritoneum at the deep ring raw. In that case, you have not made it raw. You just passed in suture and then ligated it. So that was a ligation in continuity. So when there is a ligation in continuity, there could be a theoretical possibility of recurrence. Although I have done many cases with that method also, and there was no recurrence yet. My patient do come to me. Don't think that patient might have landed with some other surgeon, because when the patient comes to you for follow-up, you come to know what is happening. So this is a preferred method, and here what you do is you try to excise a small part of the sac. See that, and while you are excising, you have to take care that you don't damage. These are the testicular vessels, and this is the vas over here. And when you are dissecting here, you take care that you don't damage these vessels as well as the vas. You can also use cautery, that is a monopolar cautery. This is how a small portion of the sac is taken out. You go inside and catch hold of the sac and then pull it inside the abdomen and dissect it out. That's it. So there is a brisk bleeding. So what I'll do is now I'll use a monopolar cautery. See, this is I'm using a cautery so that the bleeding is prevented. This was on the left side. Then we will repeat on the right side. So that is done. Then on the right side, see, there is a very tiny opening, and the same thing is repeated. Now when you are doing an open surgery, you imagine that it's such a tiny opening and such a tiny thin flimsy sac. It is very difficult. If you are not experienced, no, you will not be able to identify open surgery, I bet, because it requires a lot of practice and expertise to visualize that tiny small sac in the open method. So then subsequently, once this is done, then you take a purse string suture. I'll just fast forward it. This is how you take a purse string suture. Now, there are various methods. I am taking a purse string suture. I prefer this. If you are not confident of taking a purse string suture, what you can do is a Z-plasty. Take a suture here, then come from here this type and just tie it out. Z-plasty will be simple, but this part of the purse string is very easy, but this part passing from above down is little bit tricky. So once the suture is being taken, then you tie a knot and that's it. There is no roll of mesh. That is why I said it is very simple. But although theoretically and practically it is looking simple, but there are numerous points that I'll discuss at the end of the presentation, that what should we consider when we are dealing with a patient of hernia in pediatric age group. I'll skip this. This is nothing great. Then on the other side, same purse string is tied. So this side is done, and next again see that this part of the purse string is very easy. You have to avoid the vessels, and you see that at the region where there is a vas, this is a vas difference, this one, there I am avoiding a bite. See that I just skipped it and the vas is protected. So once this is done, and okay, I'll skip this and come back to the presentation. This was a slide which I said was very important slide. I'll just run through it. Initially I said the girl child with inguinal hernia, even if it is unilateral, it is an indication for laparoscopy. I'll discuss in few seconds. Then boys with left inguinal hernia, why I said left, because there is an anatomical and sorry, not anatomical, it is an embryological reason why left. If it is a right hernia, then the chances of hernia on the left side are remote or negligible. But if it is a left side hernia, then the chances of hernia on the right side are more than 90%. And therefore, if a boy presents with inguinal hernia on the left side, you should do a laparoscopy, because there you can easily identify. The reason, because of lack of time, we'll discuss later on. Then if it a recurrent hernia, if some surgery is performed in the inguinal canal, then there will be a lot of fibrosis. So laparoscopy is preferred, because you skip dissecting the hernial sac and just take a purse string. That's it. The female with a inguinal hernia, because ovaries don't descend, so why there should be a hernia? When there is a hernia in a girl child, always remember it could be a male pseudohermaphrodite, and don't get surprised if you find testes in the sac. That is why it is called as testicular feminization syndrome. That is a complete androgen insensitivity syndrome. So in a girl child, be cautious if it is inguinal hernia. Then other, that is hypospadias with undescended testes. Again, it is a disorder of sexual differentiation. I will not discuss this too, because it will become more complicated. And then obviously intra-abdominal testes, because undescended testes 100% of the times are associated with hernias, and very easy to deal with the intra-abdominal testes with the help of laparoscopy. Then if we are not comfortable with the open herniatomy, especially hydrocele, because the sac is very thin and flimsy, then from inside it looks very nice and rosy, and you can do it easily. Contraindication, obviously, if there is strangulation and obstruction, if there are connective, why I said, because there could be a direct hernia, and you may require some kind of a herniorrhaphy here. Only herniatomy is not going to be suffice, and therefore you have to decide whether you should go with the herniatomy only or do a herniorrhaphy. What kind of, we don't use mesh, there are different methods to do it, because we are dealing with laparoscopies, hence I am not going to discuss it here. And of course, basic infrastructure is needed, and anesthetist plays a very vital role in pediatric surgery. Always remember that hernia is a semi-emergency. No matter what age, weight, prematurity, it should always be treated on a semi-emergency basis. If you diagnose hernia today, the next OT child should be operated. Then undescended testes are always associated with hernia, and if you operate on undescended testes, you will find that the testis is inside the sac, but it is not inside the sac. There's ways to dissect it. This is not a topic on undescended testes. Just a mention, I did it here, and that's all about my presentation. All the best for your exams. Thank you very much.
Thank you, Sandeep. It was a very nice, eye-opening presentation. We will need you for.
No sooner you diagnose the hernia.
Age, you will do herniatomy only.
Acha, till what age? See, the patient, 15-year-old patient, normally you will do herniatomies. But I have a patient who was 15-year-old, and I deployed a mesh. There were several reasons, but as far as the pediatric hernias are concerned, his question is valid. Till what age you must do a herniatomy, that is, and not deploy mesh or hernioplasty. So what I'll say is maybe around 15 to 18 years of age, but you have to judge. You are a surgeon, so you have to judge when the mesh is required and when it is not required. If you see the weakness in the posterior wall, then you will have to deploy a mesh, or you will have to do some herniorrhaphy.
Actually, it's such a controversial question, and it is asked always, and there is no clear-cut answer.
Yeah,
See, the physique of a patient. Suppose a patient is of 15 years, 6 feet tall, 80 kgs. So do you just do herniatomy? No. You have to place a mesh. There is no hard and fast rule. As such said, you are a surgeon. You have You have to decide in which patient. Suppose 15-year patient, 4 feet patient is looking like body is not very well developed. Then you can do herniatomy. But in general, a well-developed adult patient in after puberty should be placed mesh.
Yeah, that's what.
What? How many years you have followed up those patients?
I started doing laparoscopies in 1999, and in 2000 I was fully doing laparoscopies. So since 2000 I have a follow-up of these patients. So it must be around now say 25 years. So patients do come to me, and I always examine them because there is a theoretical possibility because you are ligating in the continuity, and that process is very simple, that extraperitoneal one. So initially when I started, so I started with this only because it was.
Basically, I've been in 17th century also. That we have forgotten and we have started all this thing. Anyway, let's your questions, please.
It's a such a common disease. There should be multiple questions. Please ask.
Obliterating the sac. So distally there is always a chances of locular collection.
See, I already mentioned that whether in pediatric practice, whether it is hernia or hydrocele, the etiology is same. That is the patent processus vaginalis. The only difference is that through that patent processes, if the fluid comes, it is hydrocele. If the bowel comes, it is hernia. So the treatment of hernia or hydrocele is same, that you just ligate it. Forget the whatever fluid is there, that will be reabsorbed. If there is a tense fluid, you just aspirate it and leave it. That's it. It will be reabsorbed subsequently. It will take months to 2 to 3 months time to get it the entire fluid to get reabsorbed.
So the
Standard practice is to go for herniatomy. This is not herniatomy. This is ligating only. Not excessive.
No. See, in pediatric we call it herniatomy. That's it. Because you are ligating the sac. See, even if you are doing an open method now, you do the same thing. You dissect the sac and then cut it, twist, ligate.
What is the concern is that you are not creating a raw area. So your raw area will, the fibrosis will happen only if there is a raw area. That is the concern.
Sir, the patent processes is ideally shouldn't be a patent one. It has to get obliterated naturally, right? So if the processus vaginalis remains patent, that means there was some reason. We don't know what was the reason.
Is it the suture which plays the important role, especially non-absorbable suture?
Sir, I will urge the academicians to take this as a thesis topic and do a trial. And you can also do this, like you just make a peritoneum over there raw and leave it and see what happens.
Yeah.
Huh?
It is your own technique, ligation, or it is
Yeah, it's my own technique. It's not described anywhere. I did not, I haven't published.